Welcome to the Depth Perception Podcast.
We go in depth about the perceptions and misconceptions of optometry,
which includes the business of optometry,
social issues within optometry,
and life as an optometry student.
Coming straight from Dr. Jasdeep Singh Soni,
Dr. Nadia Afghami,
Dr. Douglas Akiti,
and Svetlana Nunez. We hope you enjoy this episode.
Bausch & multifocal contact lenses are designed to address the dynamic vision needs of today's presbyopes. The daily lenses like the infused multifocal, the BioTrue One Day for presbyopia, as well as the monthly lenses like the Ultra for presbyopia and the Ultra multifocal for astigmatism are all engineered with 3-zone progressives designed to deliver outstanding near, intermediate, and distance vision. The innovative design operates seamlessly to provide patients with clear vision whether they're reading a book, working on a computer, or driving. With the extensive range of parameters and the 2-ad system, you can provide a precise fitting experience for your presbyopic patients with no gaps in coverage.
Hi, guys. Pod.
Hello.
What's up?
New year.
Yeah, back on Riverside. We're back.
We
It's
are.
working. We're streaming. Am I freezing? I think not, right? We're good?
Yeah, for once. It's crazy. How's everybody been?
Pretty good.
That good, huh?
It's it's been a couple weeks into the new year here.
Yeah.
Mm-hmm.
My sister's birthday today. Super excited about that.
Happy birthday.
One of my good friends' birthday and my grandma's birthday. It's a great day, January 12th.
Beautiful. How's everybody handling the fires and has anybody been affected personally or know of somebody close to them?
I've had family evacuated. That's the extent of that, but obviously seeing all the news, wishing everybody all the best, of course.
Yeah, thoughts and prayers for sure.
I had some family friends evacuate, but personally, I know like 2 people who like their parents' house literally burned down, which is super sad and crazy. So I definitely, want to support in any way that I can. And we're definitely trying to do that.
Yeah, it's really sad. It's crazy how it just started so quickly. It was like a lot at once.
I think we haven't talked about this, but I think it's crazy that 3 of us that are from SoCal have friends that have at least evacuated or know of someone whose house has burnt down. Because it's the same thing for me too.
I mean, honestly, this is like the most devastating fire that ever happened, I think. And I was at work this week and I even asked like an older woman, she was like, I think like 76. And I was like, have you ever seen anything like this, like in your life? She's from LA. She's like, no, this is the worst I've ever seen. Like, it's really bad. In almost a week, and some of the fires only like 8% contained, 13%. It's like, that's insane.
Yeah.
You know what I realized too? I don't know if you guys know what containment means, and I just learned this like a couple days ago. But containment doesn't equal out, like fire being out. Containment means like if the fire is all of this, like it's this much, like we're 8% of the way, if that makes sense. I didn't realize that that's how you talk about a fire.
And for me, like, I went to Pepperdine in Malibu. So literally, like, Pacific Palisades, I know people from there, I know people from Malibu. And to see the crazy just houses that went on fire on PCH, like where I used to drive through every day, is insane. And it's like on the beach side. You would think that there's no possible way those houses could get on fire. And it's super sad. So I really feel for those people.
Yeah, we're definitely hoping for better days ahead. There's no rain, I think, coming anytime soon. I haven't heard much.
In the description box for the podcast, guys, we're going to put in some resources. COA also sent out an email that they're giving support to optometrists in different ways. So if you haven't seen that email and you're in California and an optometrist, we're just going to like put their resources in there too, because there's so many different people who are affected, and we want to make sure that you guys know exactly the resources that are out for you.
Yeah, if you guys need a friend, someone to talk to, we're always here for you. So don't be afraid to reach out to any one of us. Thoughts and prayers to everyone. We're going to move on to today's podcast, but we wanted to mention the things that are affecting us close to home. We're going to talk about refraction-only optometry and just kind of like practice of care optometry, basically. And the topics come about because I'm in a different mode of optometry now myself. Like I came from like a major private practice in Florida where we could like manage a whole lot to like now I'm kind of at like more of like a corporate role almost. So it's a little different. It's a little less medical. I don't do as much like red eyes and that kind of thing because we don't take medical insurance. It's mostly just like vision, right? So I get a lot of people who are like, I don't really care about the back health of my eyes. I just want glasses. And you're like, what? So that's what today's topic's going to be about. I think that we all have kind of like a different perspective of like what standard of care is. Yeah, so
Yeah.
what's refraction only mean to us actually? Like let's start there, right? So I think we're talking about like no health check, right? So if I'm doing a refraction only, like we make them sign a waiver that says like anything with your eye health is like you're waiving the liability of like me if you're not letting me do it, right? So I just literally will do auto and 4-opter, and that's it for me.
Because they signed this waiver, you don't have to go on the slit lamp.
I will, but technically, like liability wise, since they're like only getting that, like I'm not charging for like a comprehensive, right? So technically, I don't know what I always look with the 90 and I'll look even if they decline. I have to look because my brain's like wired to, right? But in some
Yeah.
practices, they don't, right? So like refraction only means like no health check at all. Like they just do refraction.
Yeah, I think obviously we were discussing before this, and we were trying to figure out, how to go about this, or what is right or wrongs to us. And I think we all aligned a little bit. And I think a lot of optometrists would align with thinking the more you could do, the better, right? But let's talk about you, because you have an interesting background in perspectives and places that you've been to. So like, let's say they are the 27-year-old, they signed this waiver. Obviously, it sounds like you said you still go on the slit lamp and you check their 90. Do you still feel like that's sufficient for them?
No, because we might be missing something. So they have to understand, right? And that's a conversation you have in the room with them so they know for next time, right? I'm like, I can't see all the nooks and crannies of your eye. You could have a hole, you could have a tear, you could have a freckle that's been growing for years and we have no idea. Like, just so they're aware and they're just like, oh yeah, they just don't care about it, and it's hard to make people care if they don't. I don't know if you guys have had that same experience, but some people are just very like, I just want my glasses, like I see fine, and they don't understand that just because you're seeing fine doesn't mean something's not wrong. That just because you're feeling like your vision's 20/20 doesn't mean that you don't have like, God forbid, like a hole or a tear. There's oftentimes I have patients that come and I'm like, you have a horseshoe tear. Like, we need to get you in like this week to get you seen by the ophthalmologist. And then they came back 2 weeks later and they're like, hey, I never went. Should I go? I'm like, yeah, you need to go. Like, they just don't understand the gravity of the situation. I'm like, your retina could just start like lifting off. You could lose vision. Then they just don't prioritize that thing. And I don't know like how to change that mindset for them, I guess, in a way as well. But I know that like some people are just like, oh yeah, I'll sign the waiver. I don't really care. I'll just do refraction. And then it's like our job to kind of educate them, right? Into like letting them know why it's important.
I think you guys said it perfectly, Nadia and Svet, in terms of education is what's most important. Like you might not get them to dilate that day, but if you educate correctly, you can. And for me, in my experience, I've seen like I'll be working up a patient and look back at their history and see they haven't dilated since 2021. And I always like educate in terms of because we always ask like everyone, "Are you okay to dilate today?" But I think the way you ask and like how you educate is what's important in having them understand like this is necessary. At the practice I work at, we do like Optos and an OCT for wellness. Some we still want to dilate like every patient as many as we can. So I always ask, are you okay to dilate? I look at the history, and if it's like a patient who hasn't dilated since 2021 or 3-4 years ago, I'm like, it's really important to dilate because yes, we did the pictures, which we get a straight shot of the back of your eye, we're just seeing right here, but with dilation we're able to get those far angles that we just can't see with the pictures. So it's important. Like you said, you could have a horseshoe tear. You could just have things that are going on in the periphery, which we would definitely miss if we don't dilate your eyes. So once I tell patients that and educate properly, they usually are like, all right, you know what? Fine, I'll do it. Or they might say, okay, that makes sense. I'll just do it next time. Like I literally have to go back to work. So education, setting up the expectations for next time. Hey, yeah, bring someone to drive with you if you feel uncomfortable driving while dilated, or just plan to not work that day, like take that day off. Then they're ready for the next time they do it. And I get a lot of success with getting people to dilate when you explain properly.
I was gonna say, I think Doug brought up a really good point in the beginning of what he was saying by like wording it properly. And I think that that stuck with me because as a student right now, there's some clinics that we go to that some patients are not used to a student seeing them. And we can have patients that get upset that like a student is seeing them versus they're here for the doctor to see them. So I've kind of been trained already, like this is what you should say to kind of set up the expectation. So like something that like I'll walk into a room and be like, "Hi, my name is Svetlana. I am your 4th year optometry intern." We don't say student because that could be triggering, so we say intern. And we say 4th year because I've been doing this for 4 years, right? And then I'll be like, "Welcome back to the clinic. I know you've been here for a few years. I'm getting familiar with your chart." Let's say they have diabetes, hypertension. Then I'll say, I was looking at your chart. I saw that you have diabetes. I was looking, are you still taking your medications? Da, 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 da. And then I'll be like, today we're going to dilate your eyes. It's important to dilate your eyes because you have diabetes and you might have bleeding in the back of your eye. And the side effects are you're going to have some blurry vision, more up close, and you're going to be sensitive to light. Does that sound good with you? And they're like, oh, okay. How long is my vision going to be blurry? I'm like, 4 to 6 hours. But if it's a patient with like blue eyes, maybe I'll put like 0.5% of tropicamide versus like 1%, then I'll be like, maybe like 2-4 hours. And then they're like, oh, okay, well, that sounds good. But it's like, we talked about this literally 2 days ago on Friday, and we were like, it's like the confidence in the room, and then like you driving the exam.
Right.
And I think if you walk into your exam room and you're like, are you okay to dilate? You're gonna have like blurry vision, and you're not gonna like it, but is that okay?
Right.
Somebody's gonna be like, no.
I've seen where it's like, you want to dilate or no? And it's
Yeah.
like,
No.
dilate or no dilate today. And they're like, what? Like, no, what is
Yeah.
that? So it's like you're saying, you have to explain, really just come in there with that confidence, tell them what's good, set the expectation, tell them what's going to happen. And they're usually like, okay, cool. It makes sense. Fine.
How
Yeah.
many times would you guys let them decline? Like after how many years is it like a problem?
2 years problem.
And
Over
then what
2
do you do?
years.
Do you dismiss them or do
No,
you like,
you're dilating today, bro.
and then if they say no, are you like,
So,
don't come back to this practice? Like how do you handle that, you know?
you have to just like, you have to brush it off like, okay, it's fine, but like the urgency is here. We'll have you sign the paperwork to say you're not dialing today, but literally next time you come, we got to dilate you. So be ready. Like,
Yeah,
just
and
set
they
that.
come next year and they're like, no. Like,
I'll
there's some people who are just always going to give you that guff, and it's like, at that point,
So
are
what do
you
you do?
taking on the responsibility or are you like, hey, you don't, like, that's not the kind of practice of care that I do here. And if it's not aligning with my values, so maybe next year you should seek healthcare elsewhere, like at that point, like, do you have the conversation or like, you can't let them not dilate for 10 years and then they'll be like, hey, I got this tear in my eyes, I had a whole tumor back there, you never really told me. And then like at that point, what are you gonna do,
I think you hit a great point. Like I feel a little differently. Like I think it goes down to your values and things like you were mentioning too, right? How you want to practice. And I think what you hit in the beginning, Nadia, was what kind of office you're in. Like when I started off in ophthalmology, working with low income patients who are maybe 30% diabetic, of course I want to push dilations more often. Now that I'm in a corporate setting, seeing a lot more healthy individuals, they're like 20 to 30 to 40. If they've done a photo last year and they don't want to do it this year and I can't see the retina, I don't think it's a big deal if they don't want to do it. And I give them the options. I think if you, to Doug's point, educate them and they know what they're getting to and not getting, I'm okay and open-minded to how they would like to go about it, as long as I give them the proper information to make those decisions. And I also think like it goes to like practicing based on symptoms as well. Like I mean, of course, if we can have that information, great, right? So I don't want to discount dilating and doing optos, but like I don't think tears just happen all the time too. Like in the sense that like symptoms happen as well. So like if a patient comes in and they have double vision, of course I'm going to do cover tests. I'm going to get more into trial framing. I'm going to get more into checking prism. But do I do that on everybody? So like I think it's just about knowing what symptoms are coming in for. Like if I have a dry eye patient, maybe I'm more likely to do a T-butt, right? Like I don't do that on everybody, right? So it's like hearing what the symptoms of what the patients are coming from in, And I'm not trying to discount dilation or Optos, but I'm not going to personally not see someone or be offended, as I feel like you just educate them and then you kind of go with it. And would love to hear your thoughts, as I threw a lot of thoughts out there.
Yeah, should we open up this box? Do we think that Optos replaces dilation? Like, do we think that that is a standard of care? Like, this has been a very controversial topic for a long time. Like, do we think that photo imaging, in a sense, is equal to like seeing a dilation, or better or worse? Like, what is everyone's thoughts about that?
I would say though you can't see the aura in an Optos, so no. But that's me coming out of school and like what I've been learning.
I am personally okay with the Optos no matter what, unless they come in with flashes or floaters, or I'm worried about something in the periphery as well. And then I still will be okay with them doing a photo, which I can use as a screener. But if I still feel uncomfortable, if I still hear it, I still may dilate them even with the photo. But the photo can still help me. Maybe you see the tear there, and then you could send them to retina right away, right? So, that's kind of my thoughts on how I feel about that. Any thoughts for you, Doug?
I think the tricky thing about just relying on photos only is, sometimes you don't get the best photos. What if you did the photos and you got half of the eyelid there? You don't have full views, so you're not even really seeing the full view you're supposed to in an Optos or a wide field. So yeah, like it's helpful for sure, but you can still miss. Like I've seen Optos where you take one picture and there's nothing there, and then the next year there's like just close to the periphery, but not even that far out. The eyelid is a little bit more open, and you might see a chirpy or something. So it's like you don't want to just rely on just the Optos, but obviously it's better than nothing.
I think too, just relying on the photos is like one part of it. But I think what JD was saying, or what like JD is also mentioning, is like there's so many other components. Like if it's a new patient and it's just photos, that's a little sus. Maybe I don't know if you guys agree with that. But if it's like a new patient, like you haven't seen them before and have never looked at the back of the eye, versus like you've seen this patient before, you've already dilated them last year, there's nothing in the periphery, they're 20 years old, you might not dilate them that next year, right? Versus if it's someone you've seen before, they're like a -8 myope, they have lattice everywhere, then you're going to want to dilate them every year. But this is like what I've learned at school. What do you guys think of like those different situations?
Yeah, I mean, I think like legally in some states, like dilation's required like at least like once every 3 years or something, and new patients like you have to. So I think it just depends on your like state laws as well. I know they teach us in school because like they don't know where you're going to end up, right? Everyone needs dilation first visit ever, they kind of do that. But then it opens up a whole other door. Like, should we be doing OCT on every single patient? Like, there's things that we can't see. Like I'll look at the Mac and it'll be fine, and then I'll be like, but their vision will be kind of fuzzy, and I'll be like, maybe we should do an Optos. And we look and they have like Barrett-Jackson that we didn't see, like, or they have like a PED that's like barely there, but it's like affecting vision that you can't always see that stuff on like a dilated exam even. So at that point, is our standard of care changing? Like, should we be doing this kind of, if we're trying to be more like full health oriented, like, do we think like a screener like that is important?
But you could also
Yeah,
argue like it
honestly,
goes based on the symptoms too. If they have a 2025 and they have an ERM, but they're not bothered, yeah, you could have done a MAC OCT and seen it, and maybe something could have been done. But if they're not bothered, they don't have the symptoms. Is that something that needs to be corrected or changed? Even though technically the problem is not being solved, if there is no like complaint from them.
I think, Nadia, though, what you just said all points to the direction of doing an OCT. Like you have somebody that's in good health, their visual acuity's decreased, you dilate, everything looks normal. Of course you would put them on an OCT next. That doesn't mean
But
I'm gonna
there's
always
oftentimes,
OCT my patients.
as we all know, they have drusen and they see 20/20. And it's not that it's not there, they're just seeing well. So at that point, like, should we be monitoring them closer? Are they going to come back the next year and be like, hey, I had a PED. Why wasn't I being watched more? Now it's been a year, like I could have been seen by an ophthalmologist. What if they have diabetes and we're not doing an OCT? We don't always do OCT on diabetic patients. Like, what if they have some macular edema? Like, it's like visual acuities are an important tool, but then It's hard to say. Just like the flashes and floaters, right? They don't always have that, but how do we know that they don't have it if we're not doing dilation, right? That just playing like devil's advocate here, right? The photos don't always show us everything, but are they a replacement? Like, this kind of like, what is the standard of care, and like, should we be doing more or should we be doing less? Like, how do you decide?
And to go back to your question, you asked, what is the standard of care changing? I think the answer to that is yes. Overall, the standard of care is changing for optometrists because we are becoming more health based and health conscious, and we're doing a little bit more each year. Like we're allowed to do more based on, our growing and changing legislation. And I do think obviously OCT is really helpful in that, but I think it just also depends on like where you're getting your eye exam. There are places that have the ability for those facilities, and there are places that don't. Like, not every optometry office has an OCT, but as I think the answer is yes, I think that like all optometrists should start to get that because there are things that are underneath that we can't see from just a regular eye exam, and maybe it's just more helpful in preventative health care.
Mm-hmm.
I think what comes challenging is like, let's say you're a manager or you're running the business, and of course, as doctors, we want to prioritize the health, right? I guess in someone else's perspective, like with balancing that, like you can't do an OCT the same day because you have to build a medical insurance to do it. And as you said, a lot of these businesses don't even have an OCT. And then if it's something you need to do an OCT for, some businesses will just write it off and do it. But then there's a time efficiency standpoint where you can like if every clinic dilated every patient, there would be a significant amount of less patients seen at every office, which affects how much money is coming into the business, which affects how the business is running, right? So there's a lot to it, whether we're talking about insurance or even like clinic flow. So like I just don't. I think that's where it comes down to like what kind of clinic you're at and how you feel comfortable. It's an art. It's a practice. Like we're all different with how we look at it and what kind of patients we're seeing.
It is an art for sure. And it's possible though. Just like you said, it depends on the flow and how you figure out that flow of how do you get your patients in and out while also utilizing the time you have to wait for them to dilate. And that's here or there. It just depends on like how you figure it out. Some clinics, every clinic does it differently, but I've seen it done pretty well at the place that I work. Patients still get in and out within like 30, 45 minutes with being dilated.
How many percentage of patients would you say are dilated on a normal doctor schedule?
A normal at my clinic or just in general?
How many patients is normal for you too? Because that's different for everybody.
Let's talk about your clinic.
My clinic, there's like 3 doctors that work at once. They see about, let's say, 25 to 30 patients a day, and probably
Each one or in total for all 3?
each one, and probably 85 to 90% get dilated.
And do you guys have
But
techs?
they utilize techs, and techs dilate, which help decrease the time in which they spend with the patient. So you're not waiting. The tech starts the dilation process. Therefore, they start dilating by the time the doctor comes in, does a refraction, then they are able to do another quick picture of the back of the eye, come back in, review the photos, do BIO 90, get them out.
It becomes tricky, yeah. But I mean, that's cool that you have a setup that does that. You really have to rely on your staff for that.
I think also too, this is what I've learned at school. Like at school, they're trying to like put us in this mentality of like risk and benefit. Like you have to know your patient, and my patient has this. What's that risk? Or my patient's just like a really healthy, straightforward person. And I've seen them before. What's the risk? And then of course, charting everything too. I think charting is a big aspect in all this.
So when is refraction only accepted? Like when would you do, like this will be the last question, right? Like when is it okay to do just a refraction only exam?
I can give my experience.
Okay.
Kind of.
When would you say like you'll be like, okay, fine, I'm only refracting you?
Let's all answer it.
Yeah.
So you can go first, but
Okay,
everybody
Svet, you go
answer.
first.
So the only experience I have refracting only was when I was at a clinic that had ophthalmology down the hallway, and ophthalmology would be seeing the patient regularly, and they would send the patient to optometry to do a refraction. But in that refraction, we would still do like the basic entrance, confrontation testing, EOMs, pupils, confrontational visual fields. We would refract, we would do slit lamp, and we would still do like a small pupil. It's like that was our refraction only. And then we would make sure that they had their next ophthalmology exam scheduled. And like, let's say this was an ophthalmology patient, but they haven't been to ophthalmology in 2 years and somehow still got into like our optometry schedule, then we would dilate them and like make sure that everything's okay, but then ultimately send them back to ophthalmology because they probably have injections, surgeries, whatever to do over there. So that was my refraction only.
Doug?
Okay. I'll say just generic, basic, keeping it standard. 18 to 35 years old. They've been there before. You dilated last year or 2 years ago. They don't have a high myopia. All right. And they've dilated last year or 2 years ago, or you did the photos today. All right, cool. We'll see you next year. We'll probably dilate you next year.
JD?
I'd probably say nobody should just do refraction only, but just for the sake of the conversation, I would say if they're not using medical insurance or vision insurance, because I think like if I'm using VSP, of course, there's things you have to check with using VSP. So that's not possible with VSP. And I'm sure with medical insurance and stuff like that. So I would say they have to be cash pay, and then they have to be seeing another provider already, and they've already done a dilated exam. And just kind of like SV is saying, if they're in ophthalmology or something like that. And so maybe at that point, maybe there's a consideration of, they came in with this chief complaint, their cash pay, the insurance does not require certain things. I will do whatever their chief complaint solves situation. That'd be my answer.
Yeah.
That's not the answer, though. The answer is, when would you do refraction only, not what the chief complaint is asking for.
I guess to stick to my answer is if they are seeing another provider and they're cash pay.
There you go.
Yeah, me too. Like, I need them to, I can't take their word for it. I need a letter that says that they've been seen recently from an ophthalmologist. Otherwise, it's like, I feel I still am going to do like 90, even if they sign the form, like I can't, because like consciously in my heart, I'm like, I can't let them go out the door without doing it. I've just seen a lot of things that are like symptomless, and a couple pods ago we talked about how I found that bear track chirpy, right? That patient had polyps, they had something else going on, and like they had missed that for years, even they even had been dilated, right? So just in my heart, I've seen it go awry. But yeah, they have to bring me a letter. I have to see it. It has to be recent. It has to be within at least the last 3 months, and then maybe. But
I think there's
interesting.
I think there's two good points. We're saying refraction only, but like all of us are saying that we're doing more than just refraction in our refraction only definition. So I think that's one thing to clear up. The second thing to clear up is like something you just brought up, Nadia. Like, do you trust another person's dilation? Like, even though ophthalmology dilates them, or not ophthalmology, but like another provider, do you trust that completely? Do you want to see for yourself? Yeah, or do you trust the patient's word? Like at the site that I was at, you could see all the notes, because it was all connected, but not every practice is like that.
Yeah, because they could have been seen by ophthalmology, but they could have just only been seen by their cataract specialist. Like, I don't know. Like, yeah, you saw ophthalmology, but did they do a retinal exam? Like, I don't, like, what ophthalmologist did you see? Like, were they doing your pinguecula, or were they checking the tear in your eye? Like, I don't know.
Yeah.
Bring me a letter.
Right.
Yeah.
So yeah, interesting. I would like to know, like, because I know there's different modes of practice, and some people practice differently. It would be interesting if we could insert here what's a voicemail thing that we can have people tell us, like how they do their. Some people do their refraction only. Like, what are their rules? Like, do we, we can kind of play that at the next pod if we can. Tell them how they can reach us voicemail wise, guys.
Speakpipe.com. This is the Depth Perception Podcast. Is where you can submit your voice, ask us a question. It could be related to this, and we'll put it on the next pod.
And it could be anonymous. You don't have to put your name if you feel shy.
Yeah, we'll change your voice.
I don't think we can do that, but we'll try.
It's okay, but I heard we have some actors on the podcast that can recite it and use different voices here.
Recite.
This is a cool topic. This is a great way to start 2025. Any other suggestions too for topic? Please let us know.
Nice. Great combo, guys.
Refraction only. I'm trying to be at a beach somewhere. Refracting only.
Wow.
All right, guys.
Bye.
Au revoir.
Hey guys, thanks for listening to the Depth Perception Podcast. Don't forget to like and subscribe on all of our platforms, including
Spotify,
Instagram,
Google Podcasts,
Apple Podcast.
YouTube. Make sure you click that button. Double tap that.
So you guys have no reason not to follow us and tune in to the next episode.
Stop wasting time.
Get in depth.
Subscribe.